remember the time when during my training days, we had very limited. We'll start now.
Okay, ma'am. Then I'll just introduce yourself. Okay, and then we'll start. So, good evening, everybody. First and foremost, I would like to thank each one of you for joining today's digital CME program on recent updates in breast cancer. I'm Dr. Naveen Parmar, medical advisor at Lupin, which is one of the top 5 biopharmaceutical company in India. I'm extremely delighted to introduce our speaker for the day, who is going to give us insights on breast cancer. She is a senior consultant working at Nutema Hospital at Meerut. She has a rich experience of 15 years. So on that note, I welcome Dr. Sudhi Agarwal. Thank you, ma'am.
Thank you very much, Naveen. And thank you very much, Lupin, for giving me the opportunity to discuss something about the problem which we very frequently encounter with, and why I'm more interested in discussing about this topic, because throughout my practice, I have seen tremendous advancement in the management of metastatic breast cancer. I still remember the time when during my training days, we had very limited resources, very limited medicines to deal with such type of patients. And knowing that someone has a metastatic breast cancer, the prognosis was always very gloomy for us and for the patient as well. The treatment was not that very effective, as well as with lots of side effects unbearable by the patient. So it is my pleasure as well as my opportunity to learn more about this problem. And I am glad to see many of my colleagues, my friends who help me, who practice with me the oncology on this platform, and I very well appreciate their presence in this seminar, this webinar. So if I start, thanks for giving such a good introduction about me. So I'm Dr. Sudhi A Kamboj, and the agenda that we will be discussing today, if I summarize, is a brief introduction about this problem, then the molecular subtypes, and the algorithm and the rationale of treatment based on the molecular subtypes. The various treatment options, the algorithm and the rationale, as I told, about the endocrine responsive tumors, the HER2 positive tumors, and the triple negative tumors, which we have broadly classified. The treatment options that we will be discussing about will be based on various trials that I will be telling. Any role of surgery in metastatic breast cancer, just a glimpse of it, and a brief outline of all the targeted therapies that we use. So it's a very lengthy topic, and I will try to summarize it. Will incorporate most of the practical points that as a clinician we must know. So we all know that stage 4 breast cancer we consider when we have an evidence of malignancy, the breast cancer, away from the breast. In any distant organ, we have the evidence of having a malignancy, then we label that patient as a metastatic breast cancer. So as I already told, in 90s and early 20s, the overall survival or the progression-free survival of the patient was not very good. But if we see, recently we had a very good progression-free and the overall survival of the patient compared to the previous years. It's a different thing that still we have challenges in metastatic breast cancer, because despite multiple efficacious agents, almost all the metastatic breast cancer will some point in time will develop a progressive disease. So it remains uncertain what the treatment option is best choice for an individual patient, especially when the disease progresses despite the treatment. And the metastatic disease continues to be an incurable disease, whatsoever efforts we put in. And the translational and the clinical research and trials are still needed. So we cannot say that it is the full stop. It is still a comma. Though we have improved a bit, but we still need more trials. and clinical research to improve the survival of such patients. And any patient, if comes, the goal of our treatment is to prolong the survival, to control the symptoms, to minimize toxicity from the patients so that like we don't hamper the overall quality of the life. Metastatic breast cancer is not a uniform disease. It's a heterogeneous disease, and many factors, they play an important role. Important ones from the patient point of view are the performance status. So to decide any therapy, we need to consider all these factors into our mind, like the performance status of the patient, any other comorbid conditions, especially the cardiac, renal, or hepatic functions, genetic differences of the patient, any prior treatment, if given, the extent of therapy that was given, and whether there was some response to that therapy or not. Disease factor is also very important. How much time was the disease-free interval before the after the first therapy and before the recurrence, the site and the volume of the disease at the time of presentation, the estrogen and the progesterone receptor status, and the HER2 new status of the patient. So the breast cancer, around 65 to 75% patients, they express the hormone receptors, either estrogen receptor or the progesterone receptor. And 15 to 20%, they express HER2 new receptors. There is a certain sort of patient which are overlapping. So they express both endocrine receptors as well as the HER2 new receptors. So there is always a sort of overlapping many of the times. And there's a third group, in fact the fourth group, which is a triple negative. So this group does not express either hormone receptor or HER2 new receptor, and which comprise of 15% of such cases. So whenever a patient presents with a metastatic breast cancer, whether that patient has received a treatment before or not, that metastatic lesion, we must always get a biopsy from the recurrent or relapse whenever feasible. Why? Because even the breast cancer subtype is very important for treatment and prognosis, because whenever there is a recurrence, we just cannot imply that its tumor type will be of the same type of the primary lesion that was previously treated, because the tumor cells, the cancer cells, they tend to change their molecular subtype. And because of that, it is always very important whenever a patient presents with a recurrence, first of all, to get a biopsy whenever possible, because we have to first confirm whether that particular lesion with which the patient is presenting is really a metastatic lesion, or it is something else, which around 1/3 of the patient, they might be having some other benign or some other malignancy. So we cannot be sure without having a proper biopsy that we are dealing with a recurrent breast cancer. Secondly, it is always required to get the molecular subtyping, because as already I have told, the molecular subtype of a tumor, even if it is recurrent, tend to change. So it is always good to get the molecular subtyping of the patient before starting any therapy. So these molecular subtypes, we have broadly classified into luminal A, luminal B, HER2 positive, and triple negative breast cancer. And it is very easy to remember. In luminal A, the estrogen receptor is positive and the HER2 receptor is negative. So hormone receptor is positive and HER2 receptor is negative, with a proliferation index of less than 14%. In luminal B, hormone receptor is positive, HER2 receptor may or may not be positive, but the proliferation index increases. The cutoff is 14%. So if it is more than 14%, hormone receptor positive, HER2 receptor may be positive or negative, then it is luminal B. HER2 positive cases are when hormone receptors are negative, but HER2 is positive, and proliferation index is more than 14%. In triple negative breast cancer, none of the hormone or the HER2 receptors are positive, in fact, all are negative, with a high proliferation index of more than 14%. So why it is important? Because it decides the prognosis of the patient. Luminal A patients have a better prognosis compared to luminal V, which is better prognosis than HER2 positive cases, and triple negative cases have the worst prognosis. So according to the subtype, if we see the 5-year survival, we can see that a patient with HER2 positive, the worst prognosis is of patient with triple negative breast cancer, and the very good prognosis is of the patient with HER2 hormone receptor positive and HER2 positive cases. And why is it so? That we will discuss later. Metastatic breast cancer is not a one-man show. It is a multidisciplinary team management, which requires medical treatment, which is most important. Radiation and surgical treatment has a limited role. Only patient with symptomatic disease, these therapies are given for symptom control or the palliative. They have a palliative role. Then we have palliative and supportive care. And nonetheless, not at all least important is the role of the nutritionist, the pharmacist, physical therapy, and the social work. Because as already told, it is an incurable disease. So at one point in time, these patients, they often go in depression, they have mood swings. So it is always good to associate them with social workers who can give proper counseling to them on time to time basis. So whenever we have to start any treatment for a metastatic breast cancer, important things to consider are the patient's goal and preferences. So it is very important to keep the patient in confidence before initiating any therapy. What is the condition of the patient? How stable is the patient to receive any treatment? Because benefit must outweigh risk. We should not do harm. It is okay to tell about palliative care and supportive measure if we see that either the therapy is not responsive or the patient is not willing or patient is not able to tolerate any therapy. So palliative care, usually any patient with metastatic breast cancer, whenever we come, usually depending upon these various conditions, we initiate a therapy. But as we all know that one point or the other, when we see that none of the things are working, then it is always okay to tell the patient about the prognosis of the disease and to consider her for palliative care and to associate that patient for palliative care, associate that patient with some palliative care nurses or some social workers. Is there any role of surgery in metastatic breast cancer? There were some controversial studies who said that with surgery one can debulk the disease and can improve the survival. But this is a study was opened in 2011, and they enrolled a patient with breast cancer who were received primary systemic therapy based on their disease. And when they saw that there's no further progression of the disease, they randomized those patients to either continue the systemic therapy alone or early local therapy. So this early local therapy was the excision of the either mastectomy or the lumpectomy, and followed by post-operative radiotherapy, and they were followed for 5 years. So the overall result, we found that there was no survival advantage of the patient who received the early local therapy compared to those who continued receiving the systemic therapy. In fact, those patients with a triple negative breast cancer, the survival was poor in those who received the early local therapy compared to those who continue receiving the systemic therapy. So it was worse even for the triple negative breast cancer. So one can suggest that there is no active role of surgery in metastatic breast cancer except for in patients with the symptomatic disease. for palliative control, like for a fungating mass which is compromising the quality of life of the patient. So this ASCO 2020 results from a large phase 3 trial showed that locoregional therapy with surgery did not improve survival in patients with metastatic breast disease, and there's no improvement with quality of life with local surgery. At this time, surgery has no role in metastatic breast cancer unless required for symptomatic or palliative measure. Systemic therapy is very important in such patients. The systemic therapy is divided based on the molecular subtype into endocrine therapy, HER2 new targeted therapy, and the triple negative therapy for the triple negative breast cancer. Since 1994, we have seen tremendous additions into the list of the breast cancer medicine. And there are various chemotherapies, as well as there are various targeted therapies that have come up, and the immunotherapies. So we'll discuss the important ones right now. So suppose a patient comes with a hormone receptor positive metastatic breast cancer. So whether we should give chemotherapy or endocrine therapy. During my days when I was doing my training, chemotherapy was the mainstay of therapy. Endocrine therapy had just came up, but it was in a metastatic breast cancer, especially in young patients, we used to give endocrine therapy, but after reducing the tumor with the help of chemotherapy, then for follow-up control of the patient, we switched them to endocrine therapy. That was our protocol during our training days in early 2000s. So endocrine therapy is now the standard first-line treatment in estrogen receptor and progesterone receptor positive breast cancer. And chemotherapy is used only if the patient has severe life-threatening symptoms where a timely response is needed. So this statement is very important, because this is the tremendous change that we have seen, and many more that we will be discussing soon. So any patient with a metastatic, this is the algorithm which we must follow. Any patient with a metastatic HER2 positive, hormone receptor positive breast cancer, we must assess what is the overall condition of the patient. Is the patient is stable enough to give us a 3-month trial to see the response? So if the answer is no, the patient has a severe life-threatening problem, then we must consider chemotherapy as a first line. But if the patient is stable, not that much symptomatic, and we may wait for 3 months to see response, to assess the response, then it is always it is always good to start the patient on endocrine therapy. And we usually see the response of the therapy around 3 months. We see the response, and then we consider whether the disease is showing any response or not. It may not show a complete response, but it may show an appreciable response at 3 to 6 months. And if we see that if it is showing a response, we continue with endocrine therapy. But if it is not at all showing a response, or it has rather progressed, then we switch to the chemotherapy. So patients with disease progression on one hormone therapy may respond to another hormone therapy. So we have various hormone therapies, various drugs available, and we see that a patient, if they does not respond to the first line management, the more and more we switch on to the second line, third line, and fourth line, the rate of tumor response decreases. So when we see that even the third line is not, patient is not responding to the third line also, then it is always better to switch the patient to chemotherapy rather than continuing with the hormone therapy. So if there is a hormone therapy resistance, then it is always good to switch the patient to chemotherapy. In endocrine therapy, the two most important medicines that we still use are the tamoxifen, which is a selective estrogen receptor modulator, and aromatase inhibitors. The commonly used drugs are anastrozole, letrozole, and exemestane. So there were studies in postmenopausal patients. So we know the basic function. This hormone, this tamoxifen, it downregulates the estrogen receptor on the breast cancer cells, and thus the available estrogen does not act, is not able to act on the breast cancer cell and does not give them the chance to proliferate. Whereas aromatase inhibitor, they block the peripheral conversion of androstenedione or testosterone into estrogen, because in postmenopausal females, the ovarian functions are already gone. So in premenopausal patient, tamoxifen is still the drug of choice, but in postmenopausal, there is always a debate regarding whether to use tamoxifen, which acts locally on the breast cancer cell, or we must use aromatase inhibitor, which only blocks the peripheral conversion of androstenedione and testosterone into estrogen. So there are 3 different studies, and almost all the studies, they gave the result that the aromatase inhibitors in postmenopausal women is always better compared to the tamoxifen in terms of the time to tumor progression than the tamoxifen. So, but if we compare whether anastrozole, letrozole, or exemestane is better, there is no proven studies, and almost any patient who is not tolerating anastrozole may tolerate letrozole, or not tolerating letrozole may tolerate anastrozole or exemestane. So we can interchange depending upon, but until proven otherwise, we must all consider the efficacy of all the 3 aromatase inhibitors equivalent. So now coming to fulvestrant, it is a selective estrogen receptor downregulator. So there was a trial, Falcon trial, where we studied the efficacy of fulvestrant as a first-line therapy. So in metastatic HER2 positive, HER2 new disease, in Falcon trial, we found that the fulvestrant had a higher efficacy, and it has the progression, it is a better progression-free survival if we compared with anastrozole, especially in patients without visceral disease and like musculoskeletal disease. It has a better survival compared to the anastrozole. So another important molecules, these are the latest drugs that have been introduced and now routinely prescribed are the CDK4/6 inhibitors. There are 3 important drugs: palbociclib, ribociclib, and abemaciclib. So what do? They inhibit CDK4. So what does CDK4 do? It is a complex CDK4 plus cyclin D1, which blocks the retinoblastoma gene. And this retinoblastoma is a tumor suppressor gene. So when it is blocked, then the tumor starts proliferating. And it has been seen that the cyclin D1 is overexpressed or amplified in a significant proportion of breast cancer, particularly in the estrogen receptor positive subtype. So it is a very landmark study. And this is a very busy slide, but if I can summarize that the palbociclib, ribociclib, and abemaciclib, they all are CDK4/6 inhibitors, and they all have almost the same efficacy and the side effect profiles are almost same, but they have some minor differences that in my other slides I will tell about it. They are now used as a first-line therapy. So there are various trials, and they are used along with aromatase inhibitors. So they are used with any hormone therapy, like either aromatase inhibitors or with tamoxifen, preferably with aromatase inhibitors. If we give them with tamoxifen, then we usually block the ovarian function. So this Paloma 2 trial compared palbociclib with letrozole with placebo and letrozole. So we can see the overall survival and the progression-free survival is better in the palbociclib and the letrozole group, aromatase inhibitor group. Similarly, is Mona Lisa trial where the ribociclib is combined with letrozole, and here again we can see the overall results are better with this combination compared to the placebo, which is in the red mark. The third trial is Monarch trial. This is compared between the abemaciclib with aromatase inhibitor and the placebo and the aromatase inhibitor. So in all these trials, the combination of CDK4/6 inhibitor with aromatase inhibitor had a significant positive results compared to the aromatase inhibitors alone with the placebo. So what about those studies were done in the postmenopausal ladies? So what about the premenopausal women with metastatic breast cancer? So in premenopausal women who tend to receive the CDK4/6 inhibitors, they all need to suppress their ovarian function either through surgery or through the LHRH agonist. So there was a study, Mona Lisa 7, which compared the pre and the perimenopausal women with hormone receptor positive HER2 cases. They did not receive any prior endocrine therapy for advanced disease, and they were randomized to receive either ribociclib or placebo with tamoxifen and goserelin, that is LHRH agonist. So we found that the combination of ribociclib with tamoxifen was better than the placebo with tamoxifen. So this is again a study in which premenopausal patients were studied. So what about any patient who was initially given hormone therapy standalone and progressed initially after showing initial response, then showed the progression with the hormone therapy? So can we give CDK4/6 inhibitors as a second line? A Paloma 3 trial was considered for this, which studied the effect of palbociclib plus fulvestrant. Fulvestrant is usually given either as a second line for patient who became endocrine therapy resistant with the first line, or fulvestrant is also considered as a first line therapy also. So a patient with hormone receptor positive pre and post menopausal which progressed on prior endocrine therapy within 12 months of adjuvant therapy, they were randomized to receive either palbociclib or fulvestrant, or the other group had a placebo with fulvestrant. So the combination group of palbociclib and fulvestrant, they had a better results compared to those with placebo. Similarly, abemaciclib plus fulvestrant had a better result compared to the placebo. Mona Lisa 3 ribociclib plus fulvestrant. So basically all the CDK4/6 inhibitors were studied with fulvestrant as a second line therapy, and almost all showed a significantly better results, a progression-free survival and the overall survival when the combination is given. So are there any adverse events with the CDK4/6 inhibitors? Almost all have the similar adverse events. Important ones are neutropenia, then thrombocytopenia, diarrhea, fatigue, nausea, and some liver dysfunction. So neutropenia is more with palbociclib, and diarrhea is more with abemaciclib. So now if we compare all the three drugs, so palbociclib and ribociclib, they are usually given 3 weeks on and 1 week off, whereas abemaciclib is a continuous medication, 150 or 200 milligram twice daily, whereas these two other drugs are once daily. So everything is almost same, except for that suppose a patient has some CNS penetration, some CNS metastasis, then abemaciclib is a more potent and important drug, which must be considered in such cases because they have CNS penetration. And in ribociclib, the QTC prolongation is high. So if we are considering ribociclib for the therapy, then we must have a regular checkup of the QTC. The ECG must have to be done. Otherwise, it may create some problem. And nausea and diarrhea are more with abemaciclib. So they all have some pros and cons, but one can consider either of these depending upon the availability and the other logistics. So what if suppose a patient who was initially given letrozole or tamoxifen relapsed, and then again given some CDK4/6 inhibitors were added, showed initial response, then again relapsed. So there is some third line therapy. This was studied, this Bolero 2 trial studied the postmenopausal females with estrogen receptor positive disease with recurrence or progression onto letrozole or anastrozole. So they were randomized to either receive everolimus. It is an oral medication, and it is an mTOR inhibitor, and exemestane, which is an aromatase inhibitor. On the other arm was a placebo with exemestane. So we saw that the overall survival and the progression-free survival was better in patient who where exemestane was combined with the everolimus. There is another study, Solar 1, which studied the combination of alpelisib with fulvestrant for patient with PIK3CA mutation. So approximately 40% of patients with a hormone receptor positive metastatic breast cancer have PIK3CA mutation. So any patient who is relapsing again and again and has failed the primary hormone therapy, then the CDK4/6 inhibitors, it is prudent to get the tissue biopsy for PIK3CA mutation as well, because if it is present, then there is a drug called alpelisib, which can be combined with fulvestrant. And it has been found that combining this drug also has a better result compared to giving fulvestrant alone. So now if we summarize, try to figure out the algorithm of such patient. The first line therapy, any patient with a metastatic breast cancer, either we can give tamoxifen or aromatase inhibitor only, or we can combine an aromatase inhibitor with a CDK4/6 inhibitor. Suppose a patient fails on the first line therapy. So if CDK4 inhibitor was not added initially, as a second line, one can add the CDK4/6 inhibitor with the aromatase inhibitor tamoxifen, or can switch to fulvestrant. And those who have already received the CDK4/6 inhibitors, then one may consider adding fulvestrant to that therapy. Okay, and if the patient again fails on either of these therapy, then as a third line, one can consider giving a combination of either exemestane with everolimus or alpelisib with fulvestrant, depending upon the PIK3CA mutation status. And if nothing is available, then one should consider chemotherapy in even in hormone receptor positive cases, endocrine resistant patients. Okay, so I think I'm clear in discussing about the hormone receptor positive patients. Now coming to hormone HER2 positive metastatic breast cancer. So HER2 amplified breast cancer we found in approximately 20% of all invasive cancers. Usually they have poor prognosis because it is a proliferative this cellular product, like it amplifies the breast. It is a pro-carcinogenic marker. So whenever it is present, it helps in tumor proliferation. So whenever it is present, these tumors are very prone for proliferation. Okay, so but excitingly and surprisingly, these patients nowadays, they live longer because of the excellent treatment options now that we have. And this excellent treatment option is the HER2 therapy, which is a must in such cases. So if I can summarize this HER2, human epidermal growth factor receptor, there are 4 types, HER1, 2, 3, and 4. So they have an extracellular domain as well as an intracellular domain. So on this HER2, whenever the receptor specific ligand it binds, these receptor, they are combined. There is a HER2 heterodimerization, and this heterodimerization then initiate a cascade of signals, which signals the nucleus to proliferate more. In a very simple term, if I can say all this. Okay, so in such patients, actually there are 4 different domains in HER2. So there are 4 few different medicines, drugs, which act on the different part or different ligands of the receptor. And but before giving medicines, anti-HER2 therapy to this patient, one must need to assess whether these patients are really responsive to that anti-HER2 medication or not. And for that, we do the IHC, immunohistochemistry, and we calculate the score from 0 to 3. So if there is either 0 or 1, we label them as negative, 3 is positive, and if it is 2 plus, then it is in between. So we have to confirm further with the help of fluorescent in situ hybridization, which tell us whether this receptor is amplified or not. So if the ratio is more than 2.2 or the HER2 gene copy is greater than 6, then we say that the receptor is amplified and the patient will significantly benefit with any HER2 anti-HER2 therapy. So the various drugs are the trastuzumab. It blocks the domain 4 of HER2. Okay, the pertuzumab, it blocks the domain 2 of HER2. So there are 2 different drugs which act on HER2 but on different domains. Okay, so when trastuzumab blocks the domain 4 of HER2, it prevents the heterodimerization and internalization. Then there is a trastuzumab emsantin that we as a short form label as TDM1, monoclonal antibody drug conjugate. Trastuzumab deroxytecan, it is also monoclonal antibody drug conjugate. And there are other small molecules like lapatinib, neratinib, and tucatinib. These are tyrosine kinase inhibitors, and they act on the intracellular portion of the HER2 receptor, and they following binding, they inhibit the downstream tyrosine kinase signaling. So whenever a patient is HER2 positive and anti-HER2 therapy is the must. Initially, we give with the chemotherapy, and following around 6 cycles of chemotherapy, when the tumor load comes down, we usually stop the chemotherapy and keep continuing with the trastuzumab or anti-HER2 therapy. So suppose if we are given an option, due to any reason, we can administer only one therapy, either chemo or trastuzumab in such cases, we must always consider giving trastuzumab compared to chemotherapy, because this therapy has tremendously remarkable results in HER2 positive breast cancer. But the trastuzumab, because it the HER2 receptor is shared by the cardiac muscles also, So because of this tendency, the trastuzumab exerts some cardiotoxic effect, and because of which the left ventricular ejection fraction declines in about 10% of the patient, and the symptomatic heart failure occurs in 1 to 4% of the patient. When we give anthracycline, anthracycline also have cardiotoxic effects. So this effect of both of these drugs, they multiply. So we always deter giving like anthracycline. Whenever we feel that we are going to give trastuzumab to such patient, we must always avoid giving anthracyclines. So the serial assessment of left ventricular function with echo for monitoring cardiotoxicity is must. Usually 3 monthly we do, or whenever patient complains of anything suggested. And but it doesn't mean that once the cardiotoxicity happens, like it cannot revert. Usually it revert back whenever we discontinue the agent. So the pertuzumab, as we already discussed, acts on the other domain, the domain 2 of HER2 receptor, extracellular domain. So usually they exert a synergistic effect without adding their toxicity. So there was a Cleopatra trial which combined trastuzumab plus pertuzumab and chemotherapy. The effect of all these compared to placebo with trastuzumab and docetaxel. So the overall survival we found was better in patients who were given pertuzumab along with trastuzumab and docetaxel. So in fact, now it is considered as a first-line therapy to add taxane with trastuzumab, to add pertuzumab to taxane and trastuzumab. So if the finances are not an issue, it is considered as a first line at many centers. And it is okay to stop chemotherapy after 6 to 8 cycles when we get the desired result. And adding pertuzumab does not add to cardiotoxicity, but the common side effect that we see with pertuzumab is the diarrhea. So what about a patient who fails on the first line therapy with HER2, anti-HER2 therapy? So then we have trastuzumab emtansine. So that is TDM1. So what does it do? It is a trastuzumab only, but an antibody, a chemotherapy drug, a small molecule is attached to it. That is emtansine. So this trastuzumab helps in targeting the drug to the affected cell only, the breast cancer cell overexpressing the receptor. And whenever it is joined, the receptor along with the antibody is internalized, and this drug enters into the cell where it inhibits the microtubule polymerization and thus inhibit the growth of the cell. So with that, we tend to minimize the toxicity, the systemic toxicity of any chemotherapy to the patient, thus not compromising the increasing the efficacy, but not giving the toxicity to the patient. So this was an Emilia study where the metastatic HER2 positive locally advanced cancer were randomized to either receive, who failed on the first line therapy, to either receive TDM1 or capecitabine with lapatinib. And the patients with TDM1, they showed a good result with a good overall survival and a progression-free survival. This. So to conclude, if suppose a patient with metastatic HER2 positive breast cancer, they relapse on the primary therapy, one should consider giving TDM1 to such patients. It is a very well tolerated agent, except for that it may cause some neuropathy, thrombocytopenia, and elevated liver function test, for which it must be these functions must be assessed regularly. So any advanced now, if I again summarize a treatment with such of HER2 positive patient, patient with advanced HER2 positive breast cancer, the first line therapy should be HER2 targeted therapy, trastuzumab with or without pertuzumab and taxane. If the disease progress, then the second line targeted therapy of TDM1. And if it still progress, and if none of the agents were given previously, please consider giving this therapy. Otherwise, one can now go to oral tyrosine kinase inhibitors like tucatinib, then lapatinib, or giving a combination of tucatinib with capecitabine, trastuzumab. So various combinations one can try. Suppose a patient is in that overlapping group, hormone receptor positive as well as HER2 positive. So after giving what should be the protocol is to follow the chemotherapy plus anti-HER2 therapy. Give chemotherapy for 6 cycles, continue with anti-HER2 therapy, and following the completion of chemotherapy, then add the hormone therapy. So one can continue with hormone therapy and the anti-HER2 therapy simultaneously. Suppose a patient comes with a brain metastasis or develop brain metastasis later in the follow-up, then if the patient is symptomatic, then it is always advisable to give the local therapy either in term of surgery or whole brain radiation, or can give a localized radiation in the form of stereotactic radiation therapy with or without systemic therapy. And suppose the patient is not symptomatic or minimally symptomatic, it is always good to give tucatinib. So this is a study. Up to 50% of HER2 positive metastatic breast cancer may develop brain metastasis. Tucatinib is an oral tyrosine kinase inhibitor approved by FDA for HER2 positive disease. So in this HER2 CLIMB randomized double-blind pivotal trial, metastatic HER2 positive metastatic breast cancer with brain metastasis who previously received trastuzumab, pertuzumab, or TDI-1, they were randomized to receive either tucatinib with trastuzumab and capecitabine or placebo with trastuzumab and capecitabine. So when they added tucatinib, they had a significant improvement in the overall survival and the progression-free survival of such patients. So it is very helpful to consider tucatinib in patients with brain metastasis in such cases. And now coming to triple negative breast cancer. So the problem with the triple negative breast cancer is because they don't express either hormone receptors or the HER2 receptor. So targeted therapy is very difficult in them, but fortunately there are some very good medicines that are coming up, that is atezolizumab, and which came in 2019. So these are immunotherapies. So how does immunotherapy work? What happens? These tumor cells are very tricky. So what they do to hide themselves from the immune cells, they start overexpressing PD-L1 receptors on their surface. So what is this PD-L1? There is a PD-1 receptor on the surface of the immune cells, which detects the PD-L1 as the own body cell. So they these tumor cells, they express PD-L1, which are considered as the own body cell by the tumor cell, and they escape the immune checkpoint. In a very simplified way, this I have told you. And these PD-1 and PD-L1 inhibitors, these are the immunotherapies, they bind to this PD-1 and the PD-L1 receptors. So they stop the binding of this receptor and antigen to each other. So the immune cells now not able to recognize tumor cell as their own body cells, and they recognize some other antigens on tumor cell and start killing those tumor cells. So the various drugs that are available are the important ones are pembrolizumab and atezolizumab, and they are now available. These other drugs are also available. Not only in breast cancer, some other malignancies, especially in melanoma, they are useful. But then they have the adverse events are significant in these patients because these antibodies like PD-1 antibody and PD-L1 antibody, they then also bind to the normal body cells also, and then they enhance the autoimmune response in the body, and because of that, the immune cells, the T cells and the B cells, they stop recognizing the normal body cells also. So the part of the body where these immune cells start attacking the normal body cells as considering them as foreign cells, because their PD1 and PD-L1 receptors are also blocked, the patient start complaining of different types of side effects. So depending upon the organ involved, they may have rash, diarrhea, fatigue, then they may have dermatological side effects, the hepatic side effects, renal side effects, and many more. So this is the very limiting factor in using immune therapy, and hopefully with more and more experience, we may be able to see whether they are really very helpful or not. So there's one study of atezolizumab and nab-paclitaxel in advanced triple negative breast cancer. So in the positive PD-L1 positive group, they combined this immunotherapy with nab-paclitaxel chemotherapy, and found there's improved survival only in PD-L1 positive group of patients. So any triple negative breast cancer, we like for HER2 breast cancer or for estrogen receptors, we have to first see whether the receptor for which we are working is expressed on the tumor cell or not. So for that, we have Vedanta PD-L1 assay, which checks if it is more than 1%, then it is considered positive. So about 40% of triple negative breast cancer test positive, but it is always good to get it checked before initiating the therapy. And if it is positive, the PD-L1 receptor is positive, then we must use atezolizumab plus chemo in first line setting if there is no other contraindication. So what else? These medicines are very costly, not in the hand of a normal person. So chemotherapy is still plays a very important part of the management of triple negative breast cancer. So now if we summarize, which is the best therapy we must consider? So anthracyclines and taxanes are still considered the first line agent. There is no evidence that precise sequence of therapies affects overall survival or quality of life. Response rate more influenced by line of therapy than the specific agent. Treatment decision must be individualized to the patient, and this NCCN panel, which most of the time we refer to, has still avoided recommending any specific first line agent. So, but taxanes and anthracycline we still use. So there is a debate whether we should use combination therapy or a single agent. In a metastatic breast cancer, most of the studies and most of the recommendation is to use a single agent. Reason, though we may have a higher response rate and a longer time to tumor progression with combination therapy, but the overall survival is usually not affected, and the quality of life is always better with a single agent. Single agent is easy to customize, and there is a less toxicity. And anyhow, one of our important goal is first not to do any harm and to maintain the quality of life of the patient. So the various agents that are usually considered: taxanes, anthracycline, hexabepilone, eribulin, and platinums. These are PARP inhibitors, usually in BRCA1, BRCA2 mutation patients we see. And there are various drugs like olaparib and talazoparib. I have not personally used these drugs, but maybe in near future, possibly if need arises, we'll certainly try to have these medicines also to see their effect. Every patient with TNBC and diagnosed at less than 60-year-old need to be tested for BRCA mutation, that we all know. And this was all a brief about the management of the breast cancer, the metastatic breast cancer. So if we summarize, metastatic breast cancer is incurable, but now with better survival and a quality of life. The mainstay of treatment nowadays is a targeted therapy whenever feasible. It is because it is more effective with lesser side effect, better patient's quality of life. Hormone therapy and HER2 targeted therapy can be concomitantly given if both the receptors are positive. Chemotherapy is now a backstage only for non-responsive or triple negative breast cancer, but still, whenever the initial therapy fails, it is the only hope that we have. Monotherapy is preferred compared to combination chemotherapy. And specific targeted therapies are also coming up for triple negative breast cancers in the form of immunotherapy, but they depend upon whether the particular receptor is overexpressed or not. Surgery has local therapy in the form of radiation or surgery has a very limited role. They only have a palliative role as a palliative care. And with this, I would like to thank you all for your patient hearing. I really appreciate the time you devoted on this weekend. And I hope I am able to touch upon many points. And I would be happy to to answer any of your question, and would be happy to share your experience, to see your experience about these medicines.
Thank you so much, ma'am. It was a fantastic session, and we had some good insights on breast cancer, especially on HER2 positive, as well as a beautiful algorithm which you showed on the management of advanced breast cancer with HER2 positivity. So are there any questions which ma'am can actually take on?
Participants can type their questions in chat box, or they can unmute themselves and ask questions.
Dr. Sudhi, ma'am. Ma'am, I had one question regarding the use of PARP inhibitors in the management of breast cancer. How often there is a new category of drug, the PARP inhibitors, olaparib, rucaparib, how oftenly they are used in the management of breast cancer today?
Actually, these are the newer modalities. As already said, I have not used these drugs, but maybe because these are very newly launched.
Yes,
the
ma'am.
problem which we face is that most of the patient, we know that around 15 to 20% of the patient, they are triple negative. And triple negative patients, especially if they are young patient, they must have a BRCA mutation analysis. But because of cost factor, still many patients, they don't get it done.
Yes.
So
yes.
This is a major hindrance, because in India, the patient, they have to pay from their pocket. Most of them are not covered from
Correct,
insurance.
ma'am.
So it is very huge burden on them. Like if we ask them to get a simple testing for like 20,000 or 25,000. So then if we even don't know whether they are BRCA positive or not, then prescribing PARP inhibitor, which also very costly medicine, it's a bit difficult. But I think maybe somewhere in the future, I may be able to have more experience about it. We'll try to learn more from the other oncologists who are prescribing, if any.
Thank you so much.
I have one question.
Yeah.
So if we talk about rucaparib, ma'am, so breast cancer is off-label indication for rucaparib. So is it interchangeable with olaparib as far as breast cancer is concerned?
Have you ever used this?
No, ma'am, I'm from Lupin Oncology. I'm from Lupin Oncology.
Okay. Actually, I don't have much idea about this olaparib and talazoparib you were asking.
Okay, okay, ma'am.
But if you have any, I would love to hear from you, your experience regarding from any other clinician. If these two medicines, I don't have much idea, but other medicines usually, because I have prescribed, so I have an idea. But certainly it is in my wish list to see the effect of these medicines also.
Okay, ma'am. Thank you, ma'am, for feedback.
Thank you. But Nagar sir is with us. Hello. Hello. Good evening, sir. Bhatnagar sir. Is he able to hear me? Dr. Chani can also give some feedback of her.
Good evening, ma'am.
Hello. Good evening. Yeah, yes, Dr.
Good
Chani.
evening. I think you have already covered everything to a great extent, and but yet we do not have any experience of using these drugs in ample, and we can't say that in which situation what would be the better. But one thing is that newer drugs are always supportive to the old regime, like as we are using molecular differentiation and then deciding what to use, it will take a little time to make up the mind. Moreover, we are limited by the financial aspect. The patient do not bear the cost, and therefore they break the treatment in between. So we cannot come to any conclusion in our Indian scenario. That is the biggest part. So I think we have to collect the data from outside, and we have to collect our data, and we have to see. It will take time to make a mind how this can be implemented and can be done.
Sure, sir. So the thing is, many few because I came across few cases which through because of which I my mind started stirring. Ki what's happening? I started taking the help of few of my endocrine oncology medical oncologist friends, and then I came to know that there's so many advancement that is already happening, and they are now routinely prescribing many of these medicines which I have mentioned in this webinar. And now what I could think now I can also very well start prescribing like abemaciclib, ribociclib, and palbociclib. So these drugs now I am very comfortable using with. And most probably now any metastatic breast cancer, which initially I used to start with chemotherapy, I will follow this regime and will use abemaciclib. The very good thing which I get to know about this medicine, that they have very good patient support program. So if any patient they purchase, because we know that metastatic breast cancer is an incurable disease. So if anyhow these patients are able to purchase for 9-month therapy or something, then their lifelong therapy is free for them. So, and the side effect profile now also I have seen. I'm very closely monitoring the patients who are receiving this therapy. And I feel now that this is the step up which I can feel myself in the field of metastatic breast cancer. So many of my hesitation has now is now gone by managing those cases. And I especially chose this topic because I wanted uh, I wanted to learn more and more about this. I wanted to give out my hesitation and to know more about these medicines. So at least few steps I have moved ahead compared to what I was previously. And abemaciclib, I must say that we can very well prescribe. It's a very convenient medicine, and only side effect is diarrhea. And some GI side effect, but the patient very well tolerated. There's not many monitoring that we need to do with such patient, and only monthly checkups these patients require. So I think this is a good thing that I got to know about it. I'm not sure about this PD-L1 testing in triple negative breast cancer. So Dr. Chani, who's a pathologist, I think you can guide us with how frequently the oncologists from Meerut or nearby are asking for this receptor testing in your lab, because you might be receiving many samples from this area.
I'm not much.
PD-L1 is still people are not requesting.
We are not getting any requisition for it.
So like suppose in any patient with TNBC, we ask for it. So is it possible, like you can provide me with the details and can find out?
Yeah, sure, ma'am. We are not doing it presently in our lab, but I can find out the details and we can outsource it.
Okay, and this PIK3CA also, like if possible, just we'll have an idea about what is this exactly and about the costing. Suppose if any patient comes, we can have this, because if we see any suitable patient if required and we do, then it will also add on to our experience.
Ma'am, I wanted to ask, like for estrogen receptor reporting, this like if it is more than 10% of cells are showing positivity, then we give it as consider it as ER positive, and 1 to 10% they have said, according to the new criteria, that we report as low positive, when only 1 to 10% cells are positive. So I wanted to know, have you come across any case with low positive estrogen receptor, and how is their response to hormone therapy?
Any patient, if reported as positive, we consider giving hormone therapy, whether it is weak or strong. With strong positivity, we expect a better result with the therapy. With a weak positivity, we may not expect that good result, but still if it is positive, we give. There are so many onco surgeons. Bhatnagar sir is here, Dr. Santosh Singh is here. So I request everyone, please give their feedback also. And it's a very close group discussion, and I can see Dr. Mahalakshmi, Dr. Mandar, Dr. Mandar is from Lupin. Okay. So Dr. Santosh is there. So Santosh, you please also give your opinion regarding like what do you do? We have a close group discussion. We can discuss about all these things. Hello, Santosh. But Nagar sir can tell us like.
Hello.
Hello. Yes, sir. Sir, just want to know your experience. Like, suppose any patient with metastatic breast cancer. So, what is how do you approach and manage such cases?
You know, this
what you first see, what is the different factors you see in the patient and in the tumor factors, and then how do you decide your therapy?
I agree. It is a difficult decision in present scenario, because we have got multiple choice and multiple parameters to assess that what to do. But what we have been doing in past and what we have been finding, it was a very clear understanding that if there is a visceral metastasis, if there is a life-threatening situation, then hormone therapy is second to be considered. Chemotherapy is first to be considered. If a patient who is already on aromatase inhibitor and develops secondaries after 10 years or 5 years somewhere, then these patients ordinarily, we never consider them that they are good for hormone treatment. We always treat them with chemotherapy. Now the subdivisions are so many, therefore we have to have a choice. But again, the hormone therapy is good for musculoskeletal situation, but for visceral disseminated disease, of course, nothing much can be done in that situation. But chemotherapy is more palliative as compared to hormone therapy.
So your point is valid and very well taken. So the thing is, if there is a disseminated disease and we have less than 3 months of waiting to see the response, then it is the chemotherapy must be considered. But suppose if there is a visceral disease, which suppose the patient is asymptomatic, but on metastatic workup, maybe with PET scan, we see some small 1 or 2 very small foci, maybe in lungs or liver. Otherwise, the patient, the performance status is good, 90 to 100%. Otherwise, okay. So, what is your take? Like, you still consider giving chemotherapy, or can we give hormone therapy, like what we have discussed, and can wait for tumor response?
In that situation, if the choice exists, we can give safely the hormone therapy and observe in 2-3 months time and see that any response something. If not there, then to stick up upon hormone therapy is probably waste of time. And for a palliation, we should immediately jump on to chemotherapy combination.
I very well agree, sir. Whenever the disease, though the patient is asymptomatic initially, but we see the disease is progressing, there is no point in giving chemotherapy further. Just then we should give the conventional chemotherapy, hormone therapy further. We should then come to our conventional chemotherapy regime and to palliate patient as much as possible. Yeah. Thank you, sir. And Dr. Santosh is with us. Santosh, can you hear me?
Yes, ma'am. You are audible.
Hello, hi Santosh. Thank you for joining us.
Thank you, ma'am.
Santosh, would like to share your experience regarding, suppose any patient with a metastatic breast cancer comes and the patient is estrogen positive, receptor positive, hormone receptor positive, and KF score is 90 to 100%. So how do you manage and see such patient and decide your therapy plan?
And the counseling first in the play is very important. And if patient can be counseled for the hormone therapy first, it should be given first, because we want to reserve chemotherapy for the worst situations.
Okay.
If she is responding well to the chemotherapy, hormone therapy, she should be continued with the targeted hormone therapy only. But if suppose patient is coming with multiple vertebral mets, impending fractures, severe visceral mets with liver dysfunction, then we should definitely think about upfront chemotherapy.
Okay, so the same thing, we see that we are not able to wait for 3 months. The patient is not able to wait for 3 months. Then we should give chemotherapy so that we have immediate response. Yes. Though there may be some chemotoxicity, but the patient will have a good response at least with that therapy. Yeah. And do you consider giving CDK4/6 inhibitor as a first-line therapy in metastatic breast cancer with hormone hormone therapy, or would you like to give hormone therapy first? And if the patient fails on that, then you consider giving CDK4/6 inhibitors?
Right now, as we are practicing in Meerut, most of our patients can't afford ribociclib or palbociclib. So, as a practice, I am not doing palbociclib or ribociclib as a first line. We use it as a second line once this option of conventional hormonal therapy fails.
Okay.
Cost is very important factor. Our patients are mostly non-affording to that costly medicines.
Okay. So one thing I just want feedback or the experience of the other colleagues, if possible, like even in premenopausal patients, whenever we consider giving CDK4/6 inhibitors, we have to suppress the ovarian function. And for that suppression, we have two options. Either we do ovariectomy or ovarian ablation, or we suppress the ovarian function with goserelin or LHRH agonist. So as a surgeon, Bhatnagar sir and Santosh can please guide me. What do you think? Doing surgery is better, ovarectomy is better, or suppressing the function with LHRH agonist is a better option, both financially as well as the efficacy?
Financially, I think there is surgical option would prove a much cost effective. And as far as efficacy is considered, efficacy will definitely be better with the surgical options.
So you are more inclined doing surgical ovarian, then this chapter is closed. Then there is no need to give gostrelin or LHRH, because anyhow it is a medicine. We cannot predict that it is 100% suppressing the ovarian function.
And how long it takes to suppress ovarian suppress, we don't know.
It takes some time. So like immediately after gostrelin, we don't start giving CDK4/6 and aromatase inhibitor. We have to wait for some time. And then after, but anyhow, this 3 monthly cost or monthly cost will be waived off if we just directly remove the surgery. Because I'm also of this point, and I wonder why people giving tend to give like LHRH agonist rather than giving surgery, rather than doing surgery. So
because these patients will learn to medical oncologist.
Oh, so they are more inclined for medical therapy, maybe. Yeah, fine. So anything want to we can discuss more? Any feedback from Dr. Chani, who is a pathologist, Dr. Santosh Bhatnagar sir? Any treatment experience with any patient? Would love to hear from them.
Certainly, surgery is more effective and sure that we have done. Any medicine we give, radiation we give, we are not sure that we have done a oophorectomy. So to get the proper thing, surgery is, and today laparoscopic oophorectomy is a very small procedure. There is no two thoughts about it. One can go ahead and very well be confident on what they are doing.
Yes.
Yes, sir. I very well agree with you, and I am of the same point that if any time the ovarian function has to be suppressed, then it is better to go directly for surgery. There's no point, because LHRH agonist, I think, must be considered when we want to preserve the fertility of the patient for any future maybe in vitro or in vivo fertility. But if ovarian function is not at all required, then better to remove the ovary rather than suppressing the function with medicines. Yeah. So I thank you all very much. I feel very delighted to see Bhatnagar sir, Santosh, Dr. Chani to have joined the session, and I find it very interesting and very informative while I was preparing for it. Lots of information adds to my knowledge, and I'm very thankful to Lupin Oncology for providing us this platform to present something on the breast cancer, this very common problem that we frequently encounter with. And many times we are stuck, and these updates that now we know will surely help us in better patient management. And we hope that we come up with many such discussions, maybe problem-based learning, so that we enhance our understanding of these diseases and to improve ourselves as a better patient care provider.
Absolutely, ma'am. Thank you so much, Dr. Sudhi Agarwal, for updating us on some good insights on breast cancer. I would like to thank Dr. Santosh Singh also, and Dr. Bhatnagar sir also for participating into the discussion. It was very valuable, and also thank you so much for providing your valuable time, ma'am. And I would like to thank all the doctors for joining us for this particular webinar. And I thank the marketing team of Lupin for organizing this event. Thank you so much, everybody.
Thank you very much once again. Thanks, Chani.
Thank you so much, ma'am.
Thank you.
So we can conclude. Thank you so much, everybody.